to be here at the European Society. My talk will be monitoring of mechanical ventilation, and this is my financial disclosures and lecture fees from Hamilton, and also a stock ownership and founder of this spin-off of my corporation. So now I would like to start from the beginning when we are when we are dealing to monitor with the patient. So we have a patient with acute lung injury, and that we have now the patient is intubated. So what happened in that situation? Just very briefly. We know this concept of barotrauma, and I would like to comment this seminal paper here. This is coefficient of filtration, edema formation, and here peak airway pressure. As peak airway pressure in this isolated model, of perfused lung increases airway pressure, there is more edema. This is one concept that, so we need, in a way, to control for pressure, but also the geometry of the lung is very nice and very homogeneous here, in normal conditions, but when we have alveoli that collapse or alveoli that they are over-distended, all these phenomena, physical phenomena, stress, strain, stretch, and shear, occur in the walls of the alveoli. So we need to pay attention when we are at the bedside with the patient to monitor those factors that I will go later on in the talk. And again, this overdistension does not occur uniformly in the whole geography of this alveolar wall. And this is a nice study where they use, in that case, optical section microscopy, and the authors realized that there are some parts of this junction between alveolars that then overdistend or distend much more compared, for example, here compared to here. And this may be, as 25% account to 25% of the initial deformation. So this is another important factor. So over and over, you have seen, these CT images of the study of Terragni from the Ranieri group, saying that even if we are using 6 ml tidal volume, no discussion about that, we should use low tidal volumes. I don't know, 4, 5, 6, perhaps 7, but in these patients ventilated with a radius net strategy, they differentiate two groups. The more protected, no overdistension, let's say no these red areas on the CT scan, but a group of less protected, and that group, they had higher plateau pressure, as you will see here. And again, if there is overdistension, even at 6 mL per kilogram, there was inflammation, in that case in the plasma, because when they measure interleukin-6, which is an inflammatory cytokine, it was higher compared with the more protected group. And just briefly, now we have this interesting data presented by Bellani and the Pesenti group. So they measure inflammation using PET and combining PET and CT in a way it is described here in the 13 patients with acute lung injury, relatively high PEEP, same PEEP for all, around 12 or 13, I don't remember, and they used PEP scan and 3 CT scans at mean airway pressure and expiration and then inspiration, and interestingly, what they found, a correlation between inflammation and plateau pressure, so the higher plateau pressure, or let's say, higher than, in that case, 26, 27, there was inflammation, and also they get a correlation between inflammation and the relationship between tidal volume of normally aerated lung and the end expiratory lung volume of this aerated lung, as you will see here. So they conclude that in aerated regions, metabolic activity inflammation was correlated with the tidal volume delivered to those regions and to the overall plateau pressure. And also at the ectatic areas, they don't find too much inflammation here. So, what to monitor? And this is the main aspect of my talk. So initially you have the patient intubated, are we dealing? Again, we need to look at two important things when we are at the bedside, two important waveforms. The airflow as a function of time and pressure. And then depending on the mode, we will know all this. Maybe this is the basics, but I would like, to explain this. And this slide and the next three to me are the most important. If we are using a square flow volume control and we have a patient with acute lung injury, then we need to monitor plateau pressure. At similar tidal volume, depending on the mechanics, in that case, the decrease in the compliance, plateau pressure will be higher. If we look at the flow waveform, there is no obstruction. The important thing, the plateau pressure, as you will see here. If we have variations in resistance, again, in a square flow, you will see how the plateau pressure is more or less the same, but if the resistance is increased, the difference between peak and the plateau is important. So again, at the bedside, look at the waveforms, but also the flow tracing. You will see here how, an increase of resistance, there is a problem in the exhalation because due to the high resistance, the time constant is prolonged, and we get all the preceding tidal volume expire here in the middle expiration, whereas here we need longer expiratory time. So again, the combination of these two. But also we are dealing with pressure-limited modes at the bedside, and there is no difference in terms of outcome in volume control and pressure control. And again, if we want to ventilate in pressure control, choosing an inspiratory time, again, if the compliance changes, the delivery of the tidal volume is going to be affected, and then what we will see is this typical flow pattern where there is also a big pause, because since the system is not elastic in this way, the distensibility of the alveoli is very low, so we get immediately the pressure, and the resultant is the low tidal volume. And also, in pressure control, it might be a high resistance, and then when the resistance increases, you will see how now, the difference between the initiation and the termination of flow is much less, and in that condition, since still there are obstructive in what is the system, the alveolar plateau is not the same as the pressure in that case at the airway, and as a result, and again, tidal volume will be low. But again, look at the flow tracing, the expiratory flow tracing, because maybe we get auto-PEEP and peak, initial peak expiratory flow is quite low compared here. So to me, this is the most important thing. When we are at the bedside, look at those waveforms to decide what we are doing there. Furthermore, we know that if we need to apply PEEP, we need to understand how is the relationships in static conditions of the pressure and volume. So many ventilators provide, a tool to draw pressure volume curves in a static condition. And if you look at here, as soon as we increase pressure, also we increase volume, and the lung starts to be recruited. And there is recruitment over all these pressure volume curve, but of course here there is also overdistension. And then in the way back, you will see that for the same pressure, here, for example, there is much more volume in that case in the lung. So some people use that criteria to set PEEP in patients with RADS. So it can be used to set PEEP in the way down of the pressure volume curve, or maybe to set PEEP here and let the lung at each tidal recruitment to get an equilibrium. And this maybe usually take minutes. So this can be useful at the bedside. So now some ventilators allow to measure recruitment. And this is important because then we discovered that there are two different types of patients, very important probably for setting PEEP in that condition. This is a nice study from Salvatore Maggiore and the group of Laurent Brochard, that they show two types of patients. This is a patient that PEEP does not produce any recruitment. Those are pressure volume curves at different PEEP levels. And if we look at the isopressure, the volume at the same pressure, there is no recruited volume at 5 of PEEP or at 15 of PEEP. Whereas in other patients applying different levels of PEEP at the same pressure, you will see how the recruited volume in the lung is different. Probably this patient needs much more PEEP compared with that patient here, because probably the compliance here, is higher compared with that patient. If we apply 20 of PEEP here, probably we will get an enormous amount of plateau pressure. Maybe, I think, is not wise. So we need to decide, but based on, in that case, monitoring tools at the bedside. Be careful also with these tools, because they allow several possibilities of drawing these pressure volume curves, and we need to choose the one that tell us the information that we want. These are, the automated method built on the Galileo, that we can draw pressure volume curves using time pressure RAM of 3 centimeters per second or 5 centimeters per second, as you will see. Since 5 centimeters per second is too fast, Also, the resistive properties take into account, and then the curves got shifted in that case to the right, meaning that, those are not static, and we need to analyze the static curve in that case using the pressure ramp of 3, because it's in static conditions that we can interpret, in that case, the pressure volume curve, choosing, lower upper inflection point, or perhaps, looking at this collapse point during this deflection, going back in that case during the deflation. Okay, just if we are at the bedside and we have a patient well adapted to the ventilator, we can look at that again at the shape of the pressure time. And this was done by the Ranierius group, that in conditions of constant flow where the system is linear, so there is in that case a linear increment on the tidal volume, the variation in the pressure as a function of time tell us if there is recruitment and de-recruitment at the end of inspiration, or, as you can see here, overdistension at the end of inspiration. So they said that the minimal stress in the lung is when, this curve is a straight line, so the slope of that curve is 1, as you will see here. And I choose that study from Salvatore Grasso, that again, using tidal volume 6, and in that case looking at the pressure as a function of time tracings in this group of patients, they found that they could present with open and closed pattern, protective pattern, and overdistension. So what they did is to adapt, in that case, the ventilatory setup to get in all patients this protective, and you will see here a radius net where, ventilation is not protected according to the stress index, compared with the ventilation, protected using the lungs, protected using the stress index approach, and you will see here immediately how, PIP get reduced. The compliance was higher here, and the PaCO2 for the same settings was less, meaning that alveolar dead space improved, in that case, choosing, an stress index of 1 without opening and closing, without, in that case, overdistension. Finally, more important, when they look at the same inflammatory cytokine in plasma, they found that using an stress index, there was less inflammation in plasma. Perhaps, this is important for the biotrauma effect, from lung to other organs, which might be important for the outcome of the patient. Now, our patients start to breathe. So again, we need to monitor, and Laurent Brochard explained, very nicely, the relationship in that case between the patient and the ventilator. But I would like to highlight some related factors that affect this interaction between patient and the ventilator. And obviously there are 2 factors related with the patient: the status of the respiratory center output, the respiratory system mechanics, disease stage and condition, and also we always must think that there is an artificial airway in place, and then the factors of the ventilator. That we are responsible, triggering, cycling off criteria, ventilator causes of patient agitation, and also dead space. If we have this in mind, we look at the patient and we look at the waveforms, I'm sure that we can do the things much better. This is an extraordinary paper of John Marini. This has been commented over and over. We can have a patient totally passive, so the machine, the ventilator is doing all the work, but if the patient actively is in inspiration in this condition in volume control, we will see how, there is, in that case, less pressure at the airway, because now the work of breathing is done part by the patient, part by the ventilator. But this is a very nice tracing that explains the physiology behind, but I would like also to show you a real tracing in a patient, because, this is more or less the same explanation. If we do more effort, there is less pressure at the airway, because the patient in that case is doing a lot of the work, is doing much work. And here is an example. This is a patient, flow, airway pressure again, and volume. And you will see the effort, the work of breathing that the patient is doing, and suddenly the patient relaxes for any reason. And this is a complete machine breath. So when we see that pattern here, this is a patient that is not in synchrony with the ventilator. I don't know what to do, but at least you need to think that this is not adequate. Maybe we need to sedate more, maybe we need to change them all, maybe we need to play with the parameters. But in any case, the physician must think what the patient wants and act accordingly. Also, double trigger. Double trigger can occur in volume control, it can occur in pressure control, but the situation is different. If it occurs in volume control, it's because the neural inspiratory time of the patient is longer than the inspiratory time set in that case in the machine. This is quite common when we want to use 6 ml tidal volume with high inspiratory flow, and then what happens is there is a double breath, and the consequence is double tidal volume. In pressure control, it's a little bit different, because then the next breath in that case is limited for the mechanics of the respiratory system, and maybe the increase in tidal volume, I mean, is not as high as was in the preceding breath. And what's looked like here, as you will see, is this pattern on the pressure waveform, and the flow is not symmetric. But the mechanism is the same. Double triggering occurs when the ventilatory inspiratory time is shorter in ventilator than the patient's inspiratory time. So maybe the patient is doing a side. We do sides all the time. Now I'm giving a talk, and probably I'm doing a side each 5 breaths, and the patient is doing the same, and maybe this is the cause of the double trigger. We don't know now yet. And this is an example of the double trigger in a normal patient. I mean, this is EKG, this is CO2 flow, airway pressure, and look at the CO2. I mean, in that case, there is no expiration. Here, there is a double trigger. This is double tidal volume, and the next breath, you will see the lung is exposed, not only to overdistension, also, I mean, in that case, to a more volume. And you will see how that happened. What's the problem here? Maybe the setting of the limit of the alarm, in that case, is very high, perhaps to avoid noise going, or alarm going all the time, and perhaps this is a mistake. But at the bedside, I mean, we need to find out all these type and interpret all these tracings. Sedation, this has been mentioned. If we, I mean, try to sedate to eliminate certain type of asynchronies, this might be good for double trigger, but this is not good in that case for mistriggers. You will see this paper of Marjolin DeWitt in this patient. So when the patients were more sedated, as you will see, the ineffective trigger index was high. And again, I mean, in order to save time, this has been very well explained by Laurent Brochard in the preceding talk. Now we have some tools, I mean, to monitor at the bedside. So I took that paper from Herasevich in the Mayo Clinic, the group of Eugen Jake, that in their information system in the ICU, they look at for this sniffer algorithm. I like that expression. What's going on? This is a sniffer algorithm. What's going on? What's going on for what? For potentially injurious ventilator settings. So they look at the blood gases, evidence of lung injury, infiltrates in the chest radiograph, or peak pressure higher than 35, or tidal volume higher than 8. And all this complex system, it sends messages, in that case, to the pager. Look at the results. I mean, this is baseline, and this is after ventilator lung injury alert implementation through this sniffer algorithm. And they found that the duration of potentially injurious ventilation was markedly decreased applying that system. The tidal volume was significantly decreased, and also the plateau maximum pressure was decreased. That was an observational study, but if we look at here, ICU length of stay and ICU free days is almost near to be significant. So there are some informatic tools that can be used in that context. And now I will use 5 minutes to explain the tool that we have developed. I mean, we have integrated digital signals from all ventilators and monitors through a common user interface, and also we use the video. Our idea is that if we integrate this through complex program systems, we can have information of what's going on all the time, 24 hours, 7 days, waveforms. So we analyze automatically waveforms. So here, I'll go through, this is how it looks like, EKG, I mean, well, saturation, arterial pressure, flow, pressure, and volume together with the patient. We have these intelligent alarms working there for asynchrony, trap gas, auto trigger, double cycling, resistant, short cycling, stress index. You will see some examples right now. We have information what's going on in a whole day, several patients at the same time, so we can go there. This is online, but then the thing is that we can review this. We have information of any mistrigger, of any breath with a stress index. And then we can review each one for teaching or maybe to analyze what's going on during the night in a certain situations that we want to examine. Also, here you will see that each time, I mean, I have, in that case, that, what's that? No? Okay. If, I don't know, what's that? Asynchrony. I have also this asynchrony here. I'm sure that you know, but this is different of here, but the system analyzes this automatically. So we set up several algorithms to provide to the clinician some information that if I am not looking all the time at the waveforms, if I am doing this, I don't see the waveform, that there are information that is missed. This is for asynchrony and trap gas, secretions as well. Maybe they are not in the tube, but they are, it can be viewed in that case in the flow pattern, the saw pattern in the flow waveform, some tendency, and also the stress index. This is a patient immediately intubated, so the patient is very well adapted, so it can calculate, in that case, stress index is higher than 1.2. Maybe, if this account for 6 hours, maybe it's important for outcome, but still, we don't know. So what I'm saying is that the role, we as a clinician, the first thing is to be at the bedside, I mean, to look at the patient, to look at the waveform, but maybe we need some computerized issues. So let me just put a short video before finishing. I mean, this is how the system interprets. There is trap gas and asynchronies. This goes together all the time. When there is trap gas, I mean, asynchronies are there. Well, how this is recorded, and an hour, 24 hours. You can review each one. Well, it's a 1-minute video, so no. And also you will see how it is reported. Okay. I mean, we believe, I mean, this is just a short clip. We believe that this is important to provide context information at the bedside. Context information at the bedside is something that is useful for we as a clinician to think and to decide of what's going on. So, to conclude, monitoring of mechanical ventilation, my conclusions will be absolutely very basic, is that displays of pressure, flow, and volume and derived loops are available now in the majority of the modern ventilators. And these loops and waveforms are important to understand basic respiratory pathophysiology. I mean, we as a clinician must understand what's going on and play a role in treatment decisions in patients receiving, in that case, mechanical ventilation. So look at the patients and look at the waveforms at the same time. Thank you very much.